I'll do my best to keep you awake, but last talk of the day. So I'm going to just talk about some cases. Justin talk about some very interesting cases. So my reports is not as interesting. So patient number one. So this patient, we did monitoring. We published this paper. We have patient with spinal dysmorphism, split cord and malformation and scoliosis. So split cord malformation, I don't know if you know about that. Split cord is a splitting of the cord. So most of the time there is bone spur in the spinal cord which split the cord, and it may be associated with tethered cord syndrome. And this patient had tethered cord, split cord, and scoliosis at the same time. So those two segments they split and then unite again. So this was, I don't know if you can see this one, this is a bony spur, so this is the whole spinal cord. So this is spinal cord and there's a piece of bone coming through the spinal cord. We typically, if it is a spinal cord, we do sensory evoked potential, motor evoked potential, and EMG. If it's about T9, T8, then we can do epidural recording too. This is a schematic diagram, so you can see the cords. So it's abnormal closing of the neural tube during. So this patient had a pre-op X-ray, so it was a mild scoliosis with a pediatric patient, not a big, and the patient. So patient underwent 6 neurosurgical or orthopedic surgery between the age 3 and 6. So patient has scoliosis, patient went under tethered cord release, then patient has a growing rod, and have every 6 months patient was going under for extension and growing rod. So when I went to that hospital, the patient already had 6 surgery, and patient came for the 7th surgery. So I got involved in monitoring. There was no monitoring done in the first 6 surgery, and everything was fine. Patient was okay. This was 6-year-old patient, and there was a bony spur was at T11 and T12. This patient had tethered cord release, removal of bony spur, repair of the subcutaneous meningocele, correction of scoliosis with Vector, which is vertical expandable prosthetic titanium rod, and expansion of Vector every 6 months. And none of the cases were monitored without monitoring. So at age 6, so we did the first case under the monitoring, and so as soon as the surgeon he exposed, and I don't know if have you done Vector cases, any Vector cases? So Vector, there's a 1 screw attached to the rib, and the surgeon he opened the screw to and as soon as he opened loosed the screw, we lost MEP bilaterally. We lost MEP, and he hasn't done anything yet. So we lost the first lower excessive and then right MEP. Stop the surgery. So this is left MEP, right MEP. So you have left hand, quadricep, leg, and feet. And so we lost the left MEP. So it was not a total loss of the, you can see the responses, and this was the about 18% decrease in amplitude. The right side has again 80 to 90% decrease. So we stopped the surgery and said, okay, send the patient back to the MRI. And when they sent the patient MRI, we found out that patient had a piece of bony spur still left, which was not totally removed, and there was a piece of a thick film which was around the phylum cord. And because of this expansion of the Vector, it caused a loss of it. So without monitoring, the patient could have been paralyzed because that surgery was done, the tethered cord release was done, the bony spur was removed in another hospital, but it was incomplete removal. There was a small bone part was still removed, and the small fascia or stick ligament was attached to the spinal cord. So because of this change, we canceled the case, and we did the post-operative MRI, and the patient was sent back to another tethered cord release and bony spur removed. And we did another 6 cases, and we did under monitoring, and patient was okay until the end of the case. This was a post-operative image of this with magic rod. So the second patient was a kyphoscoliosis with Ehlers-Danlos syndrome. Do you know what is EDS? Have you seen a patient with EDS? So patient with EDS, they have very, very thin blood vessels. So it's a collagen disease. and there are different types, type 1, type 3, type 4, and so the patient, so there are few papers published where they were exposing and patient got paralyzed. And so patient, we lost MEP and the patient woke up paralyzed without doing anything. So the vessels are so much at risk because of that compromise. Nobody want to touch this patient. So these are inherited disorders and have flexible joints and also very stretchy and fragile skin. So vascular EDS is a patient can cause walls of your blood vessels to rupture, so they can rupture very easily. This was a 16-year-old male with EDS and back deformity. Patient was neurologically intact but had respiratory and cardiac insufficiency because patient had kyphosis and scoliosis, so it was pressing the cardiac compression, and he came for surgery and the surgeon refused the surgery. He said, I'm not operating because you will be paralyzed. Surgeon went home, came back after a few months, refused the surgery again. Nobody was operating. Patient came back third time to our hospital. We admitted the patient. Next day, surgeon refused. Okay, this is like so much risk. Not. So after few months, patient came back. Patient said, okay, I cannot breathe. I cannot do. And if you don't operate in this patient will die. Will be like dead because of the cardiac complication and the respiratory complication. So we decided to operate. So we decided to do two-stage VCR, which is vertebral column resection. Have you done any VCRs? Anyone does VCR? Mm-hmm. So those are one of the worst cases you do because the spinal cord is very compressed. So in order to straighten the cord, you have to make a wedge and straighten the bone so that the spinal cord is hanging in the air while you are, so it's like open. So there's no stretch, nothing, it's just hanging in the air. So this is a pre-op image. So I don't know if you can see, this is the spinal cord. This 90-degree pre-op. So we did stage 1. Stage 1 was on Monday. We started at 7 o'clock. We finished at almost 9 p.m. It was just placing the screws and placing the rod and send the patient home, not home, to ICU. Patient was in ICU for 1 week. He came back next Monday. This was positioning. So this is the patient head, this is patient legs, this side, and as you can see, so we are supposed to make a V-shaped cut and make a stride. So stage 1 was nothing, but stage 2, 1 week later, we were doing SSP continuously. At 3:44 p.m., we informed the surgeon that there was a drop in MEP on bilaterally. So surgeon stopped the surgery and he said that he clamped a nerve, but actually it was so stretched, it was not nerve, it was a vessel which looked like a nerve. There was no blood, nothing, it was white and fell. So he removed that and we increased the blood pressure and we tried to do that. The signal came back, but it was about 70% of the amplitude of the baseline. It was never came back to more than 70%. So I had a discussion with the surgeon, said, should we move ahead? So I told him, like, if you move ahead at this time, you should be able to stop the surgery at any moment. So it's just like when you are crossing the river and there's a point, if you are tired, either you cannot reach to both ways. So you have to make a decision, either you're going to cross or you can. So that was the thing, okay, because this patient was after a patient, we will lose MEP or SSCP again, and if you lose it, either surgeon have to stop that. If he cannot stop it, keep going, patient will be paralyzed. So he decided to move, and we have good data. At 7:59, we lost MEP again. We increased the blood pressure above 100. We gave 24 milligram of IV dexamethasone, and surgeon decided to close. This again, same number. So that's the data. So if you can see, this is left hand, right hand, left quadriceps. So left hand, right hand was fine. Left quadriceps, we don't. Here we have some signal. Right quadriceps, we have signal, and then this is the first loss of it, and then it came back, but not as good as, and then you lost second time. Left leg, we have no signal. Right leg, we have a data, but we lost and it never recovered. Left foot, we have the signal on, off. This is high sensitivity, and here we lost the signal. And same thing. Right foot, we have very good signal, but it got lost. So SSCP, I don't know if you can see the SSCP. So if you have left lower cortical, transcortical, cervical, pop fossa, and right cortical, strong cortical, cervical. So we have very good stack. And if you look at this MEP, you can see how frequent I'm doing MEP. It's like every minute. It's not every half an hour, 45, it's like every 5107, 5119, 56, 51. So it's very, very less than sometimes just worried about this patient. So this have you can see a very good stack all the way, and there was a decrease, it came back, and then there's an abrupt loss of cortical, transcortical. Pop fossa was not there, and subcortical also. Popliteal fossa, you can see this is dark, it's a very congested, so you have stable, no change in popliteal fossa response. Right side you have cortical, transcortical, and cervical, and there's a same place, there's a abrupt loss, and popliteal fossa very stable, very good popliteal fossa, no changes. This was stage instrumentation. This yellow marker, that's the spinal cord, that's hanging here, so there's no bone here. So we did a wake-up test. Surgeon closed immediately, we did a wake-up test, and patient was not moving both limbs. So patient was sent to MRI, and later ICU, 24 hours, 36 hour post-op patient, and no sensory, no function, no bowel matter, everything was gone. At 48 hours, post-op patient start coming back, sensory stimuli at T10 level, nothing below. 1 week post-op patient regains sphincter control, bowel bladder. At 4 weeks, patient has hip flexors, but he was paralyzed below hip flexor. So the only quadriceps was working, but definitely. So this is a post-operative. So we can. So most of people will never publish this paper because patient got paralyzed, correct? Yeah. So I had a discussion with surgeon and said we want to publish this paper because this is the 2 paper published where the patient was paralyzed with EDS, or 1 patient died during that complication. There was no monitoring used in that cases. So these patients are at high risk of losing. So even you have a simple spine case, 1 level microdiscectomy on those patient. If you have patient with history of EDS, that's for the point we are trying to prove that. That's why you publish the paper. That if you see a patient have a history of EDS, there's a very high risk that patient is going to wake up paralyzed no matter what you do. So you have to be very, very alert about that. Yeah. Any question on that patient? Go to the next patient.
What?
I'm just going to the next patient. So the second patient, no, this was conclusion, okay. Patient scoliosis, this was a patient scoliosis, it's a very small scoliosis, not a big curve. It was 19-year-old female, intact sensory function, motor function, preoperative MRI. So we did SSCP, MEP, EMG, and EEG. This was the baseline. If you are wondering about that, this is a German machine, Metron, Inomed, so that's why the data looks very different. So we have left MEP, right MEP, EMG, and then left SSCP, upper and left and right lower SSCP baseline, all stable. So we were putting, so after exposure, 4 pedicle screws were placed on left side at T6, T9, T12, followed by the placement of 4 screws on the right side, same level, T6, T9, T12, and L1. After the last screw, we lost MEP, bilateral lower extremity, surgery was paused. We put 8 screws and we lost everything. So surgeon turned to me and said, okay, what should we do? This was a surgeon who used monitoring only once or twice a year. And rest of the cases, like he has the worst, like he never used regular monitoring. So this was one of those cases. He turned to me and said, what should I do? I said, okay, do something. Increase the blood pressure. So they increased the blood pressure from 80, it was 80 mean, we raised to 96 and then 100. Then he turned to me and said, what should we do? I said, give dextroside. So I gave 8 milligram of IV. And anesthesia was very, very cooperative. We have TIVA, and he was asking me what to do. I gave later 400 milligram of hydrocortisone. It was TSME returned to baseline on left leg, but never returned on the right leg. SSCP remained stable. So SSCP never changed. It was just MEP lost bilateral. One side came back. So we did a wake-up test, and patient was not moving the right leg. So after that, this was left MEP. We have lost and then come back, left tibial, left quad, left tibial, and then we have left hand, quad, tibial, and foot. The right side, so we have lost right hand and everything was gone. It never came back. So left side, it was lost and it came back after increasing the blood pressure and taking out the screw. So this was the closing SSP data, have very good left upper and then all the left lower and left and right ulnar, tibial, they were all unchanged, everything was good. So I went to my office, the surgeon said, okay, I'm going to call. So we took the patient to the ICU for MRI. After like 1 hour, I got a call from the surgeon saying, hey, Dr. Faisal, can you come to MRI? No, I was hoping there's something wrong, and I'm also hoping nothing is wrong because I feel bad for this, because I wanted to make sure that I have two positive, not two positive. So I went to the MRI, the chair of MRI was sitting and the surgeon was sitting. So this was the report I saw, so you can see, so the screws was removed. So this screw, you can see this is a CSF fold cavity. So there's a cavity, there's no screw, it's a cavity. It's just next to the spinal cord. And this was a small T9, T11 infarct. Can you see that? So this one, very sharp. So this infarction was, it was hit, vessel was hit, but it was not directly hitting, the screw did not touch the spinal cord, but indirectly it was causing.
So you didn't have time to test screws in that case?
No, we took out the screw. It's okay.
Yeah,
We lost
yeah,
it. There was no. So, but first thing he says, okay, just because as soon as we put the screw, we took out. And I was doing, we were doing MEP very fast. Because we picked up the changes very fast, so patient was unable to move post. So after the MRI, the patient was extubated. The patient moved the left leg but couldn't move the right leg. But later, patient has severe burning in the left lower extremity. Patient taken rehab 1 week post-op, patient was moving hip flexor. After 2 weeks later had full function motor bilaterally. 8 month post-op, patient fully recovered and has full motor function. We published this paper also. So that's the beauty or like importance of doing very quick motor evoke potential, because if you pick up a change or loss, immediately patient will have a recovery. If you pick up very late, telling the surgeon that you lost MEP is useless, is correct? It's useful, but telling on the right time, that's many times the surgeons say, what's the benefit of having MEP? You are going to tell me I lost my MEP, correct? They want to know, if I'm the surgeon, I want to know I'm going to lose MEP or something going to happen. Like SSAB, you start seeing changes, 50% drop, 30, 40, 50, you say, okay, something is gone. But MEP, you don't see that trend, you have suddenly 80% drop or have total loss because you're not doing continuously. So you want to see the change. So if you pick up the change, if you do MEP very quickly, so initially you'll see changes 80%, 70% drop. We look for 70 to 80% drop as an alert. You want to have alert all the time, not the loss. Once there's a loss, then it's already too late. This is another patient, 43-year-old, with a history of neck pain, numbness and tingling of the upper extremity. This was the patient I talked earlier. So we were tucking in, we had a good baseline left upper and right upper and lost upper SSAP. So called the surgeon, he took out the tape and moved the arm on the arm board, and the signal came back. Same thing for MEP. So I have MEP and we lost MEP. And after removing the palm, they have artifact here, so the MEP came back. So this patient was done with post-op. XLIF procedure. So in the XLIF procedure, we have different nerves at risk. So the most common nerves at risk are how many people do lateral field cases in the spine? Which nerve is at risk? Which is the number one nerve at risk? No, which nerve? Femoral? Genitofemoral. So I'll show you the picture. So the surgeon is coming from the lateral side through transverse approach. So you have L1, L2, L3, L4, and they are forming the nerve. The first nerve, which is the most ours, is L1, L2, which is genitofemoral nerve. After that, the second was femoral nerve, L2, L3, L4. So that's the femoral nerve. The third one is your peroneal nerve, because sciatic nerve has lateral part is peroneal and medial part is tibial. Tibial nerve is the last one to go. If you have loss of tibial, that means all the other nerves are gone. And most time people are monitoring a regular tibial nerve SSB for all these cases, which is like useless, kind of, because the tibial nerve is the last one to get. So the most common nerve have 28 to 30% chances. Published paper is genitofemoral nerve monitoring, and that if that nerve is damaged, patient will wake up with the groin and lateral groin pain and lateral thigh numbness for rest of life. I don't know. Groin pain is not fun to live with for rest of your life. The second nerve is femoral nerve. Femoral nerve we already covered. Dustin covered that. You can monitor motor path and sensory path. Motor path by quadriceps EMG and sensory path with Cephalus SSP. And then peroneal nerve. We always do peroneal, all these nerves. For genitofemoral, we do cremaster muscle, which put the stickers on. It's a male cross cremaster muscle on the scrotum and the female inside the labia. So these are trigger EMG responses. Again, we have a microscope connected. So you can connect your video input to microscope and or CM. So if you have CM, you can look at the CM also, images while you're doing. So this is a live image from CM, listening the cage. And this is trigger EMG from quadriceps. We have trigger EMG for cremaster muscle and the stimulation artifact. For these cases, later it's always good to have a lumbar potential. How many people have done lumbar potential? 1, 2. So try to get like experience in lumbar potential. Posterior cervical cases are the best one because patient is not already in the prone, surgeon is not working in the lumbar area. You could put the electrode there and practice as many times. When you need that, you already have experience. Because if you're doing hip case or peripheral nerve case or doing XLIF case, and you want to try that and you don't have XLIF case are very because left side up or right side up, mostly left side up, so you have very exposed lumbar area. You can put electrode in L1, L2, L3, L4. Because there's no synapses, so these are very, very stable responses. They are much better than your cortical and subcortical responses. But we do compare the left side and the right side. So if there's a change bilaterally, that means something is global. If it's a unilateral change, that's because of the surgery. Posterior cervical case, this was another patient, 50-year-old, 5'3", 195, female. She complained of pre-operative difficulty in writing, weakness in arm, which is pain in the right and upper leg of motion. Previous thyroid surgeries, right ear surgeries, wearing hearing aid. The baseline, we have motors in tricep, adductor pollicis brevis, tibialis anterior, abductor hallucis, left side, flexor carpinus, abductor pollicis brevis, tibialis anterior, and abductor hallucis on the right side. Closing, the MEP was only in abductor hallucis and on the left side, and abductor pollicis brevis, tibialis on the right side. So unfortunately, this patient, they did MEP only twice during case, one at the baseline and one was because surgeons said don't do MEP until I tell you. Sensory potential, the cortical SSP decreased in the amplitude and the right SSP responses improved, but left side remained below the baseline. EMG, so muscle exercise, the patient was given muscle exercise for exposure and patient remained paralyzed throughout the case and until the end. Mean artery pressure was 74 at 11 o'clock, and then it became 66, and then became 44, and then it became 60. It's a 66 bias. So if you have a mean of 44 and 66, what will happen?
Perfusion?
Yes, perfusion issues. So 44 is very, very low, and if you are not doing motor evoked potential, MEP, you are doing just MEP, you cannot pick up anything, correct? If you're doing SSP, the surgeon is thinking that you're doing posterior cervical, so MEP has nothing to do with that because it's anterior, and so it should affect your SSP. That's not true because ischemia affect your motors more than sensory because motors are, so you have to be, even you're doing posterior cervical, you make sure you're doing motor evoked potential in these cases. This is the baseline data, left, right, upper, left, right, lower, trainer 4. So this is the baseline, upper is left MEP, right MEP, nothing on the deltoid, nothing bicep, nothing triceps. I have tricep here, but no deltoid biceps. So this was the time where I have active, and this is the closing. So patients have no MEP at closing. Those are the two MEP traces, and this was the only right hand. So this patient woke up with full left hand paralysis. The right hand was weak before that. So the discussion we had with the surgeon after that is importance of doing continuous MEP. Now we do every few minutes. We are doing MEP with them. We are not part of the patient, but there was no good communication between the surgeon and the technologist before the surgery and anesthesiologist.
Well, I mean, we do attempt to run we do ask.
Yeah.
They say no.
Yeah, so
I mean-
so these are the cases when they happen. Then, if the surgeon is real interested, they change. They say they change. They want. Then they let you do the MEP non-stop. So they say, okay, do the MEP. I don't mind. But in order to do a good MEP, you need to make sure you're measuring the head, you're putting the electrode in the right place, you're not stimulating too high, because that patient's not moving. If the patient not moving, surgeons not. The only reason surgeons stop you because the patient is moving. This one. So this was the ACDF. I don't know if you can see the change. Two dots. So this is another case. So this was a 360 cervical case. Had a good baseline. Patient was flipped, and there was a change. So this green is the baseline, and this was a change. What's happening here? Can you tell me? Anyone? What happened?
Oh, yeah. They must be. Yeah, they plugged it in wrong.
Yeah. So when you're flipping, but the tag. So this is happened. So when you're unplugging and plugging it back. So if you're looking at this one and you don't realize this one, you say, okay, I lost my SSP. You need to cancel the case. So the surgeon canceled the case. It's okay. And surgeon was very happy because we picked up it. But the person who was monitoring the picks had changed. But that was not true because it was actually not a loss of signal. It was. You can see the cortical SSP is very delayed coming, and this one cortical is coming in. So the person who's monitoring, you say, okay, I lost my SSP. Not looking at this one. Why so early? So that's why when you're doing I was asking you guys, looking at the latency, always look, even if you see that signal, make sure it's on the right place for the latency. This is the pre-flip and then post-flip. You can see the delay here. This is the pre-flip and then post-flip. But if you're looking at this area at N20, you have lost the signal.
Yeah.
Correct. The same thing on the, this is it. And this is for the lowers, so I have good pre-flip and the post-flip signal of this patient is SSP gone, but it's not gone, it's early now. Same thing on the right side. Yeah, very good, and then it moved early. So subcortical could have done a better job. So this is a corticobulbar MEP. Justin was telling me. So what I typically do, I do like one pulse followed by the multiple pulse. You can see this is left lateral rectus, cranial number 6, left oris for 7, mentalis for facial, lateral rectus from the right side for 6, oris and mentalis. So this is a single pulse followed by the 4 pulses. So there's no response here, but you can see the response here after single pulse, followed by the multiple pulse. So if you're getting response in both, you cannot tell it's a corticobulbar response versus current shunting. So you change the stimulation to get lower thresholds of the current. So I start decreasing the stimulation and then it disappeared. But this corticobulbar response stayed there. Now this is a pure corticobulbar response. Same thing, you can see this is a direct response and this is corticobulbar. So after one pulse is present, it decreasing in amplitude, it's disappeared. So now they have on the left side, same thing on the right side. You can see the right side, you have a single pulse response. So either you can do single pulse and then motor and train pulse, but you have to go back and change pulse every time. Or you can set up a double train, which is much easier, and you can compare in each trace instead of 3. So this is the patient. So just this is one of the patient I did. So unfortunately, you can see the 2 vertebral body. This patient was quadriplegic, so there was nothing to monitor. This was another patient. This was 16-year-old driving 200 miles an hour and thrown out of the car. This was also 100 to 200 miles per hour thrown out of the car. This was when I saw this image, I was not sure should I ask the surgeon how is the patient neurologically. Does he have but I have no idea why. I had a very good signal motors and sensory for this patient. Can you imagine? Yes. No, I'm kidding.
What, in the office?
Another case, parotid case. So if you're doing ENT cases or parotid case, we can map out the facial nerve. The facial nerves comes off external cortex meatus, and then under the ear, then it enter the parotid gland. Parotid gland is the biggest salivary gland. It's a very thick gland. If you have done any dissections or cadaver study, it's very hard. And it divides into all the branches: temporal, zygomatic, buccal, mandibular, mentalis. And you have to pick, but you can mark. You can stimulate on the surface, and you can mark. You can mark on the surface all the branches before you start making incision. So it's much easier. You don't damage the gland. This is another patient who did. Any guess how old is this patient? Yeah. So this patient was brought in for this tumor resection, and when I saw that, it's like a 107 patient, and this like it has been a while because the whole face was exposed. So I asked the surgeon why he came now, why he never came in before. So the surgeon told me like, okay, he was the chair of ENT. He said the patient is very afraid of surgery and he refused to surgery, and now he's brought in forcefully by his kids. I said kids, and those kids were 91, 92.
Yes.
Okay, so they forced me. So what we did, we mapped out the facial nerve. We did all the branches of the facial nerve. Have oculi, frontalis, nasalis, oris, and mentalis. So we took out the whole skin, flipped back. You can see all the from clavicle, everything. We took this tumor out, and the plastic surgeon, they pulled back the skin and put it back. It was so vagus nerve. So again, we have superior laryngeal nerve and recurrent laryngeal nerve. Most of people, they do recurrent laryngeal. Anyone have done superior laryngeal nerve monitoring? No, because if you do only recurrent laryngeal nerve, patient can still wake up with a hoarse voice. Also have. So you need to make sure if offer the surgeon, you can put electrode in cricothyroid muscles, which is where is that? Right here. But you cannot put yourself, so you have to ask the surgeon to put that, and the surgeon can only put when he moves the thyroid gland. So because it's behind the thyroid gland, so he gives sterile needle, and the surgeon put the needle in the gland, and then you stimulate and do the testing. And once the testing is done, then you take the needle out and then go to the other side and you do that. So you can offer both superior and inferior laryngeal nerve. So again, probably you have seen all these tubes. They come with a tube. You can put a sticker. This is the endoscopic views. I took the picture from the thyroid gland. So if you see those patients, those are very small thyroid gland. But when you have a patient like this is a pre-op image. Finding a thyroid gland is interesting. So this is another one. So you have thyroid gland. The surgeon is holding this recurrent laryngeal nerve, so I can take a picture. And we took out this tumor. Patient was fine. Good release. This is the continuous vagal nerve stimulation you can use on the thyroid stimulator. You can plug the so instead of, you don't have to wait for the surgeon to stimulate. So you can just put it there and just keep doing trigger energy throughout the surgery. You can also do motor evoked. I like to do motor evoked potential for all thyroid cases because it gives me, I have full control. I don't have to wait for the surgeon. Because when surgeon tells you to stimulate, nerve may be damaged at that time. So you run and patient doesn't move that much. Again, trigger EMG from Vegas. That's it. Do you have any questions? I'm going to one second. I'm going to show you one video and then.
Is that a cool music?
You wait until the very end for you.
You're right. That's all I feel.
No, I was actually going to talk to you about that. So
It's a short video.
She's all that German club and all that nonsense.
No, no, she had it.
I might give him a call.
30 seconds, just upload it.
Because she's always been to have a German club.
Right, right.
Well, she's got one over as well.
Is there one that you would prefer if you just wanted to hear?
So this is a video of a normal vocal cord. So I just want to show you a video so you know like what's the help, how can we help in the monitoring. So you have left vocal cord, right half vocal cord, so they are moving normally. So unilateral paralysis. So this side is paralyzed and not moving. So loss of, if you're monitoring the recurrent annular and you have loss, but if you're not monitoring, that can have drastic effect. And this is the bilateral loss. If the patient has a bilateral, what was that? You cannot control. That's it. Thank you. Now go stay.
Yeah, right.